Good afternoon, and thank you for attending this webinar, the State of the Market, PACS and AI. I'm Mike Cannavo. Most of you know me better as the PACS man. I've been in healthcare since the late 70s and in PACS since the early 80s. I know some of you will say, gee, was there PACS in the early 80s? And as we see when we go through the brief history of PACS, that there actually was. I had a few short stints working on the vendor side over the years, and those who know me know that working in the commercial sector was definitely not for someone like me. I now understand when you're asked a question, no one really cares what you think. I also realize that saying, quote, why don't you both save us time and tell me what you want to hear, is not exactly the answer that leadership is looking for either. But at 25, I didn't know any better, and now I do. From a background standpoint, I've worked with nearly 350 hospitals, from large IDNs to small imaging centers and community hospitals, nearly every major PACS vendor, numerous independents, a dozen or so AI vendors, several component vendors, and both the investment and VC community. It's been a busy several decades. And while most think they know it all, eventually they accept the fact that they don't. The best clients that also realize I don't have all the answers either, but instead know the right questions to ask to get them what they need to know before committing to a project that's going to last almost a decade and have an investment that can cost them millions. The one thing I've learned over the years is that none of us is as smart as all of us. I also learned political correctness gets a client nowhere, but over the years I've become much more diplomatic. Well, sorta. I still call it like I see it, but now respect others' right to make decisions that fly in the face of factual information that was presented to them for consideration. But hey, it's all good. I've never said, quote, I told you so, except under my breath and out of earshot. Doing PACS and AI correctly is about understanding where we are, where we're going, and above all, what it takes to get there. If you have questions, I definitely want you to go ahead and put them in the Q&A section, and at the end we'll get to them. So now, without further ado, let's take a look at the state of the PACS and AI market, where we are, where we're going, and what things will look like when we finally get there. Okay, and we're going to do that. So here we are, ups and downs of the PACS marketplace. It's a lot of fun. PACS history. Believe it or not, PACS has been around since the before the 80s, actually, with a company called Colorado Video that made an analog CCD closed circuit TV setting that was used. Wasn't really diagnostic, but it was a good start. In the early 1980s, we had academia in Europe and the US, including the University of Kansas, which was Sam Dwyer's gig, UCLA, the Hospital University of Pennsylvania, and several others. In the mid-80s, there was a few commercial PACS vendors. AT&T Philips had a product called ComView. You had Raytel, you had 3M, you had Kodak. You had GE and IBM, who combined for a product called Integrated Diagnostics. Siemens, the Department of Defense, their DIN-PACS project, and of course Fuji had their plate-based computed radiography. 1990s was the advent of teleradiology, the growth of PACS, and the establishment of standards like DICOM and HL7. Early 90s, 1993 actually, we saw the first filmless site that, if memory serves me correct, was put out there by DR Systems. And then you had a host of companies, ABP, Dataspan, DR, you had Hammersmith in the UK, a host of different people. In the 2000s, the mid-tier market, the 150 bed to 400 bed market expanded. it went from a tool to a necessity. And film companies, major independents, and others really got into the market. You had market growth and shakeout, and then in the 2010s, and then in 2020 forward, AI comes into play. Definitely comes into play. And it's going to be interesting. And then you had the evolution of on-premises versus SaaS solutions as well. Many of those were native AI versus enabled AI, and there were a few new PACS as well. Let's look at the marketplace and how it has changed in the past 7 years. 2018, we had a lot of PACS vendors. In 2025, we had fewer vendors. 2018, it was PACS, RIS, and others. 2025, it became enterprise imaging, not just PACS, not just RIS, but the integration of the electronic medical record, of digital pathology, of lab, and others. Here's the biggest change that I've seen. In 2018, you had 50 AI vendors. Right now, there are well over 1,000 FDA-cleared AI algorithms from roughly 550 or so vendors. It's gone tenfold in 7 years. On-prem solutions were basically where hardware was put in, and we had deconstructed PACS back in 2018. Now almost everything out there is cloud or SaaS based except for point-to-point teleradiology. Support was internal support where you had PACS administrators with the vendor. Now almost all of the support is done by the remote vendor, and business continuance is a big deal. Back in 2018, hospitals, since they were paying for it, they pretty much made the decisions on what happened. Now radiology input is key. RADs in 2018 were almost all on site. Now RADs are, with the exception of interventional in some other areas where they need to come in, are often off-site and remote and can be anywhere in the world, as shown by several of the major groups. Voice recognition and dictation vendors, still the big two or three, Nuance being one of them. And now VR and dictation is actually part of PACS. And then you had archiving and VNA vendors back then. Now your disaster recovery is in the cloud, and there are fewer VNAs. So where are we now? Let's take a peek. PACS cloud solutions are taking over from on-prem. SaaS, which is an acronym for software as a service, is replacing hardware software sales. I mean, the reality is the vendors weren't making more than about 5% on it anyway, and it was causing more aggravation than it's worth. You still have integrated risk PACS. Disaster recovery is done in the cloud right now, and data migration is a key. Data normalization, which is a fancy word for making sure that everything is called the same, is key to making prefetching and other information a success. And enterprise solutions are starting to gain a foothold where you have PACS, RIS, medical records, pathology, lab, etc. With the return on investment a key, and it's not just a radiology solution, but you've got the chief information officer, chief technology officer, chief medical officer, all putting together a vision for the future. AI, over 1,000 FDA-cleared algorithms from around 600 companies. Interestingly, though, there's a very limited clinical use of AI. It's primarily academia and larger facilities. That's not an across-the-board statement, but just primarily. There's a lot of evaluations going on where AI is put in and it's used for 3 months, 6 months, or longer without being paid for. Interestingly enough, there is starting to be collaboration between academia and vendors to develop products, um, and a lot of academia who are developing their own algorithms as well. I predicted several years ago. I predicted that there would be partnerships with AI vendors, and there are definitely a lot of mergers and acquisitions and partnerships going on. There's some reimbursement that's finally being shown. Most of it is class three. Most of it is from an ultrasound vendor who's doing it. But you're going to see market shakeout soon, very soon. This market can sustain maybe 100 vendors tops, and consolidators like Blackford and others will certainly play a role. So what's the market segmentation? Uh, Two vendors, Visage and Sectra, are battling for the high-end market. Others you see on occasion, but it's mainly the 500 bed and up market that they're going after, 400 bed, 500 bed market. And mega deals are the norm, 20 to 200 million and up. Now we're going to get to class in a second, but it's interesting. These two vendors are for the top market, and Sectra for the past 7 years has won that top market, which is a plus for Sectra. They've done an exceptional job in the marketplace. But the reality is Visage is not included in the class rankings. And the reason for that is fairly complex. But I just heard from Brad Levin at Visage, and he said basically the information is there for class to use, and they elected not to go ahead and include them in the class rankings. So they're a good vendor. They're an excellent vendor. Both of these vendors are excellent, but they go head to head. No one really owns the mid-tier market. That's 75 to 80% of the hospitals and imaging centers. That's the 100 to 500 bed counts. Deals can be as low as $150,000. Typical deal is $750 to $1 million, and it could be up to $3 million or more. Excuse me. The features and functionality are the primary distinctions between the vendors in this marketplace. And the low end market is still driven by price. It's point A to point B teleradiology. Now here's one of the biggest changes in the marketplace. RADs are now buying PACS to control their own destiny. They don't want to be controlled by the hospitals. So they're starting to buy their own PACS so that they can use it forever. The hospitals still preserve the investment that they have in the PACS, but the difference is the RADs use their own workstations and workstation software in dictation to go ahead and do their own readings. So they can connect to 3, 4, 5 different PACS because that's being sent to the cloud and then being sent back down to be read. The imaging center market is typically a starting point for RADs buying it, and we're starting to see a lot of that. And then they have connections to the hospitals that they read for. Cost. Before 2000, PACS were prohibitively expensive. A lot of proof of concept back then, but not a lot of people spending an extraordinary amount of money. COTS, which is off-the-shelf hardware, drove pricing down some, but still required some fairly significant investments, capital investments specifically. And frankly, most of the margins were made on implementation and service. As I said before, you're going to be lucky to have a 5 to 7% margin on the hardware, and it wasn't worth the aggravation to the vendor to go ahead and provide hardware. Limited available capital led to development of software as a service, otherwise known as per-click pricing, post-COVID-19. And the reason for that was several. Biggest one is hospitals didn't have a lot of service, and hospitals didn't have a lot of capital, and the cost for an on-prem solution was significantly higher than a SaaS solution. Now, keep in mind, SaaS is a loss leader for vendors their first 2 years. They're not really making any money. At best, they're breaking even. But every year thereafter, they make money. And with a SaaS, most of the hardware is in the cloud and includes everything: hardware, software, service, updates, upgrades. There's no pain for the end users. Everything is included. And it's also important to have PACS in the cloud because a lot of AI needs to be done with higher powered hardware that resides in the cloud as well. So when you do prefetching and merging together, they're all together. Now, there is, with a SaaS, there are implementation costs and network costs extra, but they're not, in the big picture, they're not that significant. Features and functionality. Those are the key differentiators between all of the PACS out there. Workflow orchestration is key, as is pre-caching of work lists and priors. And you'll see when we get toward the end how this is all going to work. AI-driven improvements in dictation and transcription can show up to a 30% improvement in reduction in time. It's not across the board, but there have been studies that have shown upwards to 30% reduction. The biggest challenges that you run into, though, is lower procedural reimbursement, and RVU-based payments require increased radiologist productivity. In a nutshell, they need to do more with less time. So simplicity and automation are key. The question that comes down to, in everyone's mind, is will AI replace RADs? Years ago, 5, 6, 7 years ago, I said, no, absolutely not. And yet you still see articles coming out that saying AI will replace radiology. Trust and reimbursement are still key factors, as is return on investment. It's a complex issue as well. Who do you sue if something isn't found by AI or AI has a misinterpretation? So what is being looked at now and where the marketplace is they're evaluating workflow, dictation, and cybersecurity. Cybersecurity almost never was looked at in any depth. Now that's actually number one. And since cost isn't a major factor under SaaS, they need to look at improvements to reading as being key. How can a radiologist read more studies in a short amount of time while making sure that the outcomes are improved as well? AI, 3 areas. AI needs accuracy, integration with the PACS vendor, and a cost that can show an ROI. The evaluation period is typically 60 days to 6 months or longer. And the areas that it's most used at right now are mammo and large vessels, or LVO. Now, years ago, going back probably 4 years or so, about 4 years, there was a program called NTAP, which is dealt with new technology. And it initially paid up to $1,040 per study. Now you're seeing prices coming down. 2 of the largest reading groups are charging $40 for AO and mammo, and making a profit on it. The question it comes to, and this is going to be another discussion for another day, is do people have equal access? Can we go ahead and charge one person $40 out of pocket, and another person doesn't get the AI capability? Is that legal? Can they do it? Can we have equal access? It's just a question of time before somebody says, my study was not given the same consideration as another study because I wouldn't pony up to the bar and spend $40 for AI. So the selection process right now, for existing sites, they use class to justify the couple of vendors they look at. But the reality is, almost every site I've worked with over the past 5 years generally know who they want, and go for it. I want to use vendor A, I want to use vendor B. How do I justify my decision to go with those vendors? That's one of the reasons they bring me in. And then I try to kind of backdoor it and say the vendor offers you A, B, and C, and you can show a return on investment that way. Radiology group purchases typically go ahead and will evaluate everybody from the newest vendors that include AI to the oldest vendors that have been around forever. And radiology group purchases are not as political, for lack of a better way of putting it, as hospital purchases are. You rarely see an RFP, a request for proposal, done anymore, except to cover their tails. And the reason for that deals with a lot of the benefits of a SaaS. You can try it before you buy. They call it a sandbox. Basically, a radiologist can go in and play in the sandbox and see it, like it. They don't have to wait for a vendor to come in with hardware and software and do a standalone demo. What they can do is the radiologist can have access to the sandbox. They can play with it, do what they want to do, and then say, okay, well, I like the workflow of vendor A better than vendor B. Interestingly enough, larger vendors are actually faster in making decisions than smaller ones. Some of that deals with internal politics, some of that deals with money, but larger sites typically know what they want, have the backing of the upper level administration, the folks who control the money, and can go ahead and buy quicker. From an AI standpoint, the decision is pretty basic. What companies work with their existing or proposed PACS? You don't want to develop a customized, what's called as an API, or an application program interface. You want to have an interface to their PACS already. So that kind of limits what AI you can use. There are interface costs and there are per click use costs. Those are still fairly significant, but you're going to see those costs dropping very, very quickly. And we'll discuss this a little bit further as well. But AI, the bottom line is it's often the radiologist's choice and the comfort factor with it. Rads still aren't 100% comfortable with AI for a number of reasons, mainly trust. But we've also killed ourselves, and the marketplace has killed themselves by starting out years ago saying AI was better than a radiologist. And by the way, doctor, can I have your support? That was kind of dumb. So where's the future? We're coming, toward the home stretch here. AI is an integral part of radiology imaging and interpretation. It is not going to become optional. Now, are there going to be cost adjustments? Absolutely. The question is, who's going to pay for it? Is CMS going to adjust the Medicare and Medicaid reimbursements? Are private insurers going to pay X amount of dollars? That remains to be seen. But the reality is AI is here, it's going to be used, and it's going to be part of the future. AI may also do the first line reviews in certain studies. I foresee within the next 5 years or so that AI will be the first line for screening MAMs. And if AI finds it negative, then it's a question of, does the radiologist get a much lower reimbursement for reviewing those MAMs, or do they just pass that cost on to the vendor providing the software? Same situation with chest x-rays. This is going to be a very controversial comment, but there's going to be a market shakeup. As I said before, at best, 100 of those 600 or so vendors are going to live, and only those that have about $5 million or more will survive. It takes money to stay in this market, and it takes money to promote it. Another very controversial statement, but it is an accurate statement over my 43 years in this industry. It's not always the best companies that go ahead and are the industry leaders. It's the companies who are the best marketed who go ahead and survive. Marketing is key to the survival of any and every company. I can't tell you how many PACS companies I've seen that had very good products that went by the wayside because they ran out of money. So they got to dig deep and they've got to get some. Conversely, while we're on this topic, the opposite is true. Companies that have 50, 60, $70 million investments in them, you have to worry. It's great that they're surviving and they're marketing and they're considered industry leaders. But a lot of the venture capitalists and the people making investments are looking to make at least 5x or 10x money back. So if they have, I'll throw a number out, 50 million, and they're looking at 10x return, just for the investors, they have to pull 500 million out of the sale of the company. Plus you have other people. Who has that deep a pocket and how good is the product? Something for discussion for another day. So 5 million, maybe 10 million investments that you have, the company will survive and do well. PACS will also have AI reporting mandatory. We look at several companies that offer Rad AI is one that comes to mind right away that have AI reporting mandatory, and some of the newer PACS out there like Synthesis, who is the sponsor of this, has integrated AI reporting as well. Data migration and disaster recovery become unnecessary. Almost everything is done in the cloud, and this is something I've had a real issue with for years. Is what is known in the industry as an incidental finding. To me, and it's just my opinion, there's no such thing as an incidental finding. If you find it and it's something that needs to be acted on, it's not incidental. And what you're finding with AI is AI finds a lot of what they're calling incidental findings. Well, finding's a finding, and a lot of time it needs to be acted on. So how's reading going to be done in the future? You're going to get image data from the modalities sent up to the cloud to be processed. Appropriate AI will be processed in the cloud at the same time and merged with image and other data. So you have the imaging data from the modalities comes up to the cloud. The associated studies will be prefetched and ready to come down for interpretation from the radiologist. And then the AI study will be processed and sent down along with that. So all the data and AI interpretation will be merged and sent back to the radiologist for interpretation. One of the things you can't do is to go ahead and wait for AI to go ahead and make its interpretation. Some of the AI studies, not all of them, but some of the AI studies can take 3 to 5 minutes. Most radiologists will not wait 3 to 5 seconds, let alone 3 to 5 minutes to get an interpretation. So when that data comes back down to be read, the AI interpretation is there with it. And then they can just click on it and pull it up. And then you've got 3 options. AI agrees with the radiologist diagnosis, which is, going to be 90% of the cases or more. AI indicates that XYZ, and the RAD doesn't see it. But the dictation would be AI indicates XYZ that has not been visually verified, but in a typical radiologist CYA move, but cannot be ruled out. And again, you've got to put that last part in there because that's crucial. Then the third part, for those that are AIs that are frankly, more than just computer-aided diagnosis or CAD, is AI has made a diagnosis of ABC. Then you should consult with your specialist to confirm or rule out the diagnosis made by AI. That's the ultimate goal of AI, is that it can read it, it can interpret it, it can bring together all the data from all the other clinical systems and go ahead and make a diagnosis. But that's not quite where we are right now in the industry. But that's the future. That's how things are going to be done. The only thing I was going to get in trouble saying it, but the only thing that you're not going to see in those options is a radiologist dictating, AI found something that I didn't. That will never happen in this lifetime. So what it will be is AI agrees with the diagnosis that I've made, and in the background, not saying anything, but thank you AI. I almost missed that one. So, but that's kind of it. So let's go ahead and we'll have some a time for open questions and discussion. I actually got a few questions in advance, and then we'll go ahead and take some questions from the audience as well. One of the things that I was asked is, when do you anticipate AI will be part of mainstream reading? And I would hope it would be sooner than later, but a lot of that really depends on CMS, the Center for Medicare and Medicaid Services, restructuring their payment and insurance companies arriving or ponying up to the bar as well. So again, you have to show that return on investment. More importantly, it depends on the AI companies realizing that the day of NTAP type reimbursements are over. You're not going to see up to $1,040 for a single study, or even $300 for a study. You may get $3 to $5 for using AI for a study, but make it up in volume, and that's the key. And then the question is, how do they put that in the SaaS fee? Companies also, frankly, need to be very careful, because there are several IDNs and academic facilities that are creating their own algorithms that might negatively impact the use of third-party systems. Everyone's saying how easy it is to create an algorithm. Well, if that were the case, you wouldn't have companies having 30 and 40 software engineers working a year developing an algorithm. And I sure as heck couldn't do one. But it's happening all over the place. You're seeing two that come to mind, I think, was Microsoft and Mayo are working together, and Rush Presbyterian, I think, and Google are working together, if memory serves me correctly. Second question that I got in advance was, where can I find the best resources for what's going on in the marketplace? And it takes a lot to figure out, to separate the wheat from the chaff. There is a lot of bull, there's no polite way to put it, going on out there. You can read a great story about a company's algorithm, but when you dig deeper, you find out that the sample study involved was 100 cases or less. And that's kind of crazy. It's even hardly worth a mention. 1,000 cases is a little better. 10,000 cases is a really, really good start. And there was a couple of cases in Europe where they had over 100,000 studies. Now you're talking a serious assessment worth noting. So you've got to dig deep, not just look at, gee, I like this, but how much was done in terms of the algorithms, developing their algorithms, and making sure everything, from leveling the plane on down is good. You've got The two you got typically you read 2 lines or so that give you a good starting point, but you really need to dig to find more. Um, Places that I look at consistently are the imaging wire, which is a great resource. AntMini.com, who I've been writing for years, and both are excellent for industry news. And then you got forums like radhq.net, which is just over a year ago, to find out what the rads are talking about. So you've got to cover both ends. There's at least 15 other journals that I read regularly. And the information is good, but the industry has changed. A lot of the articles, a lot of the releases you have are what I know as pay for play, and that is they're paying to get the articles in print, so the objectivity could be questionable. I look at least 30 different journals in the course of a given week to look at everything and to find out what the heck is going on, and then I research it from there. The last question that I got from folks that had looked at the presentation ahead of time was, should I look at existing PACS in the marketplace only, or wait and see what new comes up? There's a few new PACS that have been shown in the past year. Again, the webinar sponsor, Synthesis Health, is one of them. And there's a few more that are coming down the pike that you should see by year's end. I could tell you who they were, but I'd have to shoot you. So that's not going to work. The big thing is forget about who the vendors are, but have you done your own needs assessment and identified what you want out of the new PACS and AI? You don't need to develop and issue an RFP. Frankly, I found that's an absolute waste of time and money. You got to know what you have. You got to know what you want, and when you want it. If you're going to do any data migration and data normalization, understand that takes time, as do cybersecurity reviews. The longest time, believe it or not, comes from the contracting side of the house, internal hospital or radiology group contracting with the vendor. Vendors usually are a heck of a lot more flexible these days than facilities are. But, and you can take 6 months or longer to get through the contracting process alone. So I would plan about a year out and go from there. And those are pretty much the only questions that I've gotten in advance. If you have any questions, let me know. You can always contact me directly at my email, which is pacsman@ix.netcom.com. You can call my cell, and we can talk. But I'd be more than happy to answer any questions that you have, and to expand a little bit further on where we are. And with that, we will go ahead, and I will say thank you very much to both Synthesis and RadHQ for sponsoring this webinar. And we are finished. Best of luck to everybody in terms of your project. Have a great one.